sessions of Jaipur surgical tutorial. What we thought that present a seminar or a journal, we will transmit these sessions also on JST. So whosoever is free, welcome to attend. And Dr. Anand will keep on informing you on the WhatsApp group about these sessions. So today, Milind, Dr. Milind Akhani, who is our MCH second year senior resident, he is going to present a seminar on role of adjuvant therapy in retroperitoneal tumors. We also have Dr. Nitin Kunteta, one of the senior members from surgical oncology department with us. Just to make some points. Yes.
Good morning, sirs. Today I'll be presenting a seminar on role of adjuvant therapy in retroperitoneal tumors. So,
single view karo. Single करने ही करो. ये नहीं करता कोई.
हाँ ये बंद होता है. So first we look at the introduction. The retroperitoneal tumors are extremely rare. Approximately 70 to 80% of primary retroperitoneal soft tumors are malignant, which only account for 0.1 to 0.2% of all the malignancies. Based on the type of cells and origin, they can be classified into benign and malignant, being from adipose tissue as lipoma and liposarcoma, smooth muscle as leiomyoma and leiomyosarcoma, connective tissue as fibroma and malignant fibrohistiocytoma, fibrosarcoma, and chondrosarcoma. Whereas from the muscle, if the cell of origin is muscle, then it's known as rhabdomyoma as well as rhabdomyosarcoma. We will be more focusing on two of the tumors because mainly soft tissue sarcoma as well as germ cell tumors, because adjuvant therapy is established in only two of these conditions, whereas in other conditions the evidence is probably lacking and surgical resection remains the treatment of choice in other type of conditions. So we'll begin with retroperitoneal sarcoma. Retroperitoneal sarcoma are the second most common malignancy after soft tissue sarcoma of the extremities. They account for the 10 to 15% of all soft tissue sarcomas and 30% of all malignant retroperitoneal tumors. R0 is still the most potential treatment to cure patients with localized disease, which means if the adjacent organs are invaded, they are often not preserved. Hence, the role of adjuvant therapy becomes more important because in cases of retroperitoneal sarcoma, most of the times it is very difficult to achieve the R0 resection, and most of the time R1 resection is achieved. The rate of complete resection ranges from 41 to 76%, and local recurrence remains high even if negative margins is being achieved, which leads to poor prognosis and with 5-year-old survival ranging from 39 to 65% and high mortality of 20 to 75%.
So one point that by definition, lymphomas are not included in retroperitoneal tumor. So they are. Similarly, tumors arising from retroperitoneal organs like kidneys, adrenal, pancreas. When we say retroperitoneal, we don't mean that. So in the exam, when you mention retroperitoneal tumor, you have to be clear that you are talking of these tumors which Milind has detailed and not lymphoma. They are mentioned as separate entities.
Based on NCCN latest guidelines version 2023 version 1.2023, TNM classification is T1 is tumor less than 5 centimeter or less in greatest dimension. T2 is tumor more than 5 centimeter or less than or equal to 10 centimeter of greatest dimension. T3 is more than 10 centimeter and less than equal to 15 centimeter in greatest dimension, and T4 is more than 15 centimeter in greatest dimension. N1 disease is regional lymph node metastasis. M1 is distant metastasis. It also includes the grade based on FNC-LCC histological grading system, which includes total differentiation, mitotic count, and necrosis score of 2 or 3 as G1, 4 and 5 as G2, and 6, 7, or 8 as G3. Based on this, it has been classified into stage 1A, 1B, 2, 2A, and 3 and 3B. The tumor differentiation, it almost the sarcomas resemble closely as adult mesenchymal tissue. Hence, histologic typing is absolutely necessary before initiating a treatment in this patient. Mitotic count are also involved with 0 to 9 mitosis per 10 high power field and 10 to 19 mitosis per 10 high power field and greater than 20 mitosis per 10 high power field. Tumor necrosis is evaluated as 1 and 2 less than 50% tumor necrosis and grade 2 as greater than 50% necrosis.
Although TNM classification T is size based, but you have to remember that for practical purposes, size is not that important because you can have a small tumor, but it is sitting in a precarious area. For example, if it is close to celiac axis, if it is close to the iliac vessels rating, it may be unresectable or difficult to resect. On the other hand, all of us have seen huge tumors, kilograms and kilograms. You will see newspaper reports, कि मैंने इतना बड़ा tumor निकाला, but they just come out easily. So size does not correlate always with ease or difficulty of resection.
We'll go through the guidelines first, then we'll see each of them in detail. Initially, when the patient presents with us, it is necessary to diagnose and stage this disease. Imaging modality mostly used is CT scan and pre-operative tissue diagnosis done by image-guided core needle biopsy. On that basis, we decide whether tumor is resectable or unresectable. If there is this disease is resectable and on biopsy, it can be either GIST, desmoid tumor, and sarcoma. So if it is sarcoma, then R0 resection is necessary to achieve curative treatment. We can also give neoadjuvant therapy, as been shown in few of the latest trials. It can be given in selected cases, especially those tumors which are at high risk or those tumors which may require post-op systemic therapy. After that, surgery can be done to achieve R0 resections. Intraoperative radiotherapy, as we'll be discussing further, can also be used in such settings. So, if we have achieved R0 resection, there is generally no need to have adjuvant therapy unless if it is high risk for metastatic diseases. If we have achieved R1 resection, as happens in most of the cases, then it is necessary to give adjuvant chemotherapy along with it or radiotherapy. And if it is R2 resection, then what we do is we wait for we give adjuvant therapy. We downstage it again. We again resect that disease. Same case with recurrent disease. In recurrent diseases, if adjuvant therapy is not given pre-operatively, then neoadjuvant therapy is not been given pre-operatively, then we can resect the disease and again subject it to neoadjuvant systemic therapy.
Are you going to tell us what are these highly selected cases?
Yes.
Have you selected them?
In case of stage 4 disease or unresectable disease, observation if asymptomatic and a systematic therapy if it is symptomatic.
Systemic, not systematic.
Systemic therapy and surgery, palliative surgery for symptomatic control, that is debulking surgery, in which even R2 or R1 resection is acceptable in those conditions. If we have a resectable recurrent disease, then primarily surgery can be done to obtain oncologically appropriate margins. We can also consider neoadjuvant therapy in these settings and radiotherapy if not previously given. However, if once radiotherapy is given, post-operatively radiotherapy is not advised because of the toxicities caused by it. We'll see that in coming slides.
So these are one group of tumors where re-resection is always to be considered, and because recurrence is very high, as we said, and there are instances. I myself have done 7 re-operations in a patient. Every time I would tell the patient, you will have nephrectomy, you will have a stoma, but fortunately the tumor just came out. So whenever you have a recurrence, unless there is a definite contraindication on imaging, should always give it benefit of re-operation to the patient because sometimes they can come out easily.
So we begin with the surgical resection. The treatment modalities starting with surgical resection. There can be a standard or simple complete resection. Some of the groups practice extensive or compartmental resection. However, we'll see which one is better and which is proposed in the NCCN guidelines.
So these are standard terms used?
Yes, standard. Extended or compartmental resection. Initially, it was a study done in 2009. It was a French retrospective study. They had done nephrectomy in 42% of cases and colectomy in 30% of cases. However, the local recurrence rate was 44%, which was in in standard resection, it was around 60% at that time. There was no difference in overall survival. The surgical complications were increased, which was 16% in extended cases, whereas in simple resections, it was around 10%, which also lead to increase in mortality. 13 patients died postoperatively because of surgical complications, whereas 3 patients died intraoperatively because of bleeding.
So basically, this study in which they have compared between the extended resection and the simple extended resection. Then we can see the overall survival is not different.
Another latest study was done by Gronchi et al. In 2008.
Sorry, the local recurrence rate 4%.
Yeah, in the simple resection, it is 60%.
वहाँ लिखा नहीं
नहीं, वो से comparison
लिखना चाहिए ना दोनों पर कि दोनों में कितना डिफरेंस था जिनने एक्सटेंडेड रिसेक्शन किया उनमें लोकल रिकरेंस कितना हुआ जिनने सिंपल रिसेक्शन किया था उनमें लोकल रिकरेंस कितना था.
However, sir, mortality increased and complications were increased.
इसमें कितना था mortality?
Mortality was 10% and here mortality is 16%.
तो p-value significant था.
One more study done by Gronchi et al. In 2018, sir. They have again compared standard resection with compartmental resection. Here the local recurrence rate, as can be seen in standard resection, is 48% compared to 28% in extended or compartmental resection. The distant metastasis rate is 13% in standard resection. However, it is more in compartmental resection, that is 22%. Overall 5-year survival rate was almost similar, 51% in standard resection and 60% in compartmental resection. What NCCN proposes is, these are the principles of surgery, that pathologically negative resection margins should be achieved. We have to plan closed margins or even microscopically positive margins may be appropriate to preserve critical structures such as major vessels, nerves, bones, joints, especially in the setting of multimodality therapy where we institute adjuvant chemotherapy or radiotherapy in these patients. The biopsy site should be excised en bloc with definitive surgical specimen planes uncontaminated by tumor. If a tumor is close to or displaces major vessels or nerves, they need not be resected if the adventitia or perineurium is removed and the underlying neurovascular structures are not involved with gross tumor.
These tumors, even when they are malignant, and the plane of dissection has to be outside the capsule and whatever adjacent organs are there. So as he has mentioned, the dispensable or resectable organ, in order to achieve an margin, take that organ or part of the. If it is a organ cannot be or should not be resected, then obviously you accept an R1 kind of resection.
Yeah, as you said, that you have to take it 1 centimeter over.
Yes. Yes.
Still clearance is sufficient.
Yes.
So, experimentum or X-ray can be taken as facial clearance. That is sufficient for these treatments.
So that is the difference between these tumors and adenocarcinoma. For example, pancreas, even if it is abutting portal vein, you would tend to resect the portal vein, but that does not hold true for retroperitoneal tumors. As Dr. Kundeta said, you don't aim for 5 millimeter or 1 centimeter margin. It is that you will be plane between the tumor and the structure which is to be preserved.
Radical excision or entire anatomic compartment routine necessary. So NCCN is mentioned that they are not supposed to.
So it depends on when we resected. Assess the organ where it is invaded. If it is frankly invaded, then only it should be removed. Otherwise, you can take facial as the clearance.
Surgical clips may be placed to mark the periphery of surgical field and other relevant structures to help guide potential future radiotherapy. If closed suction drainage is used, the drain should exit the skin close to the edge of surgical incision. In case of re-resection or radiation is indicated, the surgical margin should be documented by both the surgeon and pathologist evaluating the resected specimen.
This placing of clips and metal clips is important. We tend to forget that sometimes. Whenever you anticipate that you will have to give radiation post-operatively, for example, an R2 resection, colon which is infiltrating the posterior parietes, and you have kind of done an incomplete resection, you know that there is a gross residual disease, you must place clips all around the margin. That is very helpful to the radiation oncologist. I mean, you can say they can plan the radiation, use CT or MR or whatever, but if the metal clips are placed, it becomes very easy for them to decide which area they have to target.
Sites, as sir has said, Generally, retroperitoneal sarcoma are big tumors, and generally they receive radiotherapy after that. So always put lip or superior laterally margins. As well as in OT note, it has the diagram should be made and should be clearly made out what was the extent of disease and where you have placed the clips. So that later on, when the radiotherapy is planned, it is planned to the appropriate area where it is needed. Otherwise, such a big radiation therapy to abdomen will use mobility of radiation also. It is given to the whole abdomen. So the diagram representation in the OT note should be very clear. And specifically where the structures are involved in taken fascia as a clearance, and you're suspecting that it may be invading during surgery, put a clip there also and mention in the OT notes that so the reason that we have put a clip here. That helps in treatment also.
In terms of radiotherapy, it can be given as preoperative, just neoadjuvant, intraoperative, or postoperative. There was a study done by Nussbaum in 2016 who compared preoperative or postoperative radiotherapy with surgery alone. The conclusion was radiotherapy either given preoperatively or postoperatively improved overall survival compared to surgery alone. So RT can be administered either as a neoadjuvant therapy for patients with resectable disease or as a primary treatment for those with unresectable disease. In general, this NCCN panel discourages adjuvant RT for retroperitoneal or intra-abdominal soft tissue sarcoma, except for highly selected cases where local recurrence would cause undue morbidity. If free resection is not feasible, adjuvant radiotherapy may be considered in highly selected patients who have not received neoadjuvant RT to attempt to control microscopic residual disease. There was a trial done by Strass in 2018. It was a phase 3 trial who compared neoadjuvant radiotherapy with plus surgery with surgery alone. However, the trial stopped because of the high cases of recurrence and toxicity. So the sir, even the median recurrent survival was also less, 4.5 years compared to 5 years in sequence-free survival. So, but however, the conclusion was that neoadjuvant radiotherapy is not much beneficial in this kind of patients.
What morbidity was there in this trial when they gave neoadjuvant radiation therapy?
Grade 3 and grade 4 toxicities, mainly hematopoietic toxicities, were done with neutropenia and pancytopenia in these patients. Certain patients will also had subjected to bleeding in those patients. Gut bleeding was more common in those patients.
You can't mention a trial without giving the citation. You must give the citation. Nussbaum also, you did not give the citation.
So, neoadjuvant RT can be considered for selected patients with retroperitoneal and intra-abdominal STS who are at high risk for local recurrence. What they give is 50 gray of external beam radiation therapy. That is 1.8 to 2 gray per fraction, followed by surgery with clips and consideration of intraoperative radiotherapy boost for known or suspected positive margins at the time of surgery. Adjuvant external beam radiotherapy boost is discouraged in this setting. Adjuvant radiotherapy, according to NCCN, it discourages providing an adjuvant EBRT boost for retroperitoneal or intra-abdominal soft tissue sarcoma. However, if it is necessary in highly selected cases, bowel should be safeguarded from tumor bed with omentum or other tissue displacers to reduce the risk of RT-related bowel toxicity.
How do you prepare omentum for as a flap during surgery? Suppose you've done a resection, you want to put an omentum in that area. How do you put omentum for that?
Based on single vessel, mostly gastroepiploic vessels, we can prepare the
right and left. There are two pedicles done on both sides. You can cut the omentum in the mid. And have two pedicles now. Based on that, you can put depending on the location of the tumor, where the place. But
Based on the epiploic branches of the gastroepiploic vessel.
if RT is not given prior to surgical resection, consider follow-up with possible neoadjuvant ABRT at the time of localized recurrence. If the localized recurrence occurs, then we can give neoadjuvant RT at that time, only if it is not given previously. So, sir, this concept of intraoperative radiotherapy, there have been multiple small studies yielding conflicting results. One of them says use may be provocative. Larger studies are required, sir. What they do is they give 10 to 12.5 gray for microscopically positive disease, whereas 15 gray is given for gross disease, gross margin in these cases.
Intraoperative, they have
Yes, sir.
So the advantage of intra-op is that one, as you said, you can give a large dose in one fraction, and second, you can take out the bowel, you can protect the organ, you can target only the gross residual disease area. It is.
So, we have already discussed what are the principles of radiation therapy, which are given according to NCCN. So, coming to neoadjuvant chemotherapy for high risk tumors, so it is not in these factors have not been universally accepted, but most of the groups have concluded that tumors greater than equal to 8 centimeter of any grade 2 or grade 3 tumors less than 8 centimeter, grade 2 or grade 3 locally recurrent tumors, and tumors with inadequate surgery can be considered as high risk tumors and can be subjected to neoadjuvant therapies, including chemotherapy as well as in radiotherapy.
When you say tumor, it's a benign also.
Yes, sir. No, sir. If free of tissue diagnosis, sarcoma, only for sarcoma.
Sarcoma.
So, adjuvant chemotherapy, there was a trial done, sarcoma meta-analysis collaboration performed 14 randomized trial meta-analysis of 14 studies, which compared adjuvant chemotherapy to follow-up in some cases RT after surgery with variety of sarcomas. The result showed that doxorubicin-based chemotherapy prolongs local and distant recurrence and overall improvement in recurrence-free survival and is associated with decreased recurrence rates. However, the overall survival was not significant. This has been contradicted in the latest meta-analysis performed by Jiangji Li in 2022, which concludes that there is a benefit in adjuvant therapy for retroperitoneal sarcoma in the overall survival setting as well. And this meta-analysis has also been incorporated in the latest NCCN guidelines of 2023.
So you show an abstract like this, and then you want to read one sentence. First you show this, then you copy that sentence and enlarge it. Type it again and blow it out so that everyone can read it.
These are the therapies, general regimens which are used generally worldwide. AIM doxorubicin, AIM therapy containing doxorubicin, ifosfamide, and mesna, and ifosfamide, epirubicin, and mesna. Sir, this is the protocol which is been also followed by our institution as well with AIM regimen. So other regimens are doxorubicin and dicarbamazine for leiomyosarcoma or ifosfamide if it is not considered appropriate, sir. So in cases of metastatic or first advanced disease, it is anthracycline-based regimens which contains doxorubicin, epirubicin, and or AIM regimen can also be given in this patient, sir. Sir, newer leratinib and entracentinib are the newer anti-RK gene fusion positives are for used only for sarcomas only, but more of them need to be studied extensively as well because overall they have not been shown to be significantly beneficial in overall survival in these patients. If this fail to work, then newer regimens include pazopanib and eribulin, which are also PD-1 analogs and antibody inhibitors which can be used, but still they are also not proven or for using these therapies. They are still on the trial basis in these conditions.
What is A in AIA?
Anthracycline, sir.
No. What is the other name?
Adjuvant.
Adriamycin. What is mesna?
Mesna is a radioprotective agent which protects against.
It's not a chemotherapy.
No, it's not.
Protects the bladder. Generally giving with the ifosfamide combination always. Bladder toxicity to decrease the
Next we come to malignant germ cell tumors.
अल्फा सैलिसिलिन होता है शायद उसका कॉम्बिनेशन होता है.
So, according to NCCN guidelines, the first line chemotherapy regimens based for germ cell tumors are BEP, that is bleomycin, etoposide, and cisplatin, which has to be repeated every 21 days. Or other regimens are VIP. However, this VIP regimen has a high risk of febrile neutropenia and hence granulocyte colony stimulating factor should be used while using this VIP regimen.
So you want to say testicular tumors are retroperitoneal sarcomas?
So germ cells, if they are retroperitoneal tumors.
then it will come in the category of this. Otherwise, they are separately known as testicular tumors only. Then you find non-symptomatic germ cell tumors and symptomatic germ cell.
The second line chemotherapy regimens in case of recurrence or if the first line therapy fails, again include a TIP, which includes paclitaxel, ifosfamide, and cisplatin, which are repeated every 21 days. The high dose chemotherapy regimens include carboplatin and etoposide. They are administered 5, 4, and 3 days before peripheral blood stem cell infusion for 2 cycles. There are also third line regimens for metastatic germ cell tumors, in which the preferred regimen is carboplatin and etoposide, and paclitaxel and ifosfamide.
Show a slide like this on the screen. If it is such a small text, you split it into two and enlarge it. Nobody can.
Actually, sir, वो करते ना तो ज़्यादा better रहता.
So, वरा type करो.
What should be clear is when you will see it's a retroperitoneal tumor.
If it is undescended testis, it is.
Imaging you find an undescended test. How to proceed? Straight away chemotherapy or how?
No, we can.
Biopsy. You have to remove the whole mass of the testes and do histopathological evaluation of it, and then plan according to the histopathology. It's non-seminomatous or seminomatous, sex4, whatever tumor it is type of, and then accordingly you have to plan this.
But if it is a tumor in an undescended testis, also you would do a excisional complete excision. No,
because it will seed up, seedling will be there of the tumor cells along the path. Second thing is it's a barrier system there in the testes. So the chemotherapy doesn't reach there generally. And later on resistant clones will come out. So the testes has to be removed completely.
So the principles of surgery for in case of germ cell tumors, radical inguinal orchidectomy is the gold standard for diagnosis and initial management of suspected testicular cancer.
What is radical inguinal orchidectomy?
Sir, we are removing the lymph nodes also along with.
Radical inguinal orchidectomy, placing an incision in the inguinal area, removing. Put a clamp. This is known as Shivashu's maneuver. Or put a clamp at the internal opening. Vascular clamp. Pull out the testes from the inguinal area and then cut it, suture it, ligate it, leave a longer colored thread there so that later on when you do retroperitoneal lymph node dissection, remove this spermatic intra-abdominal part of spermatic cord also. So for this is known as how radical inguinal orchidectomy.
Prevent tumor. One is testis sparing surgery can be done in conditions.
Orchidectomy is discouraged.
Because sir, higher rates of local recurrence
So many layers of scrotum, there are 6-7 layers of the scrotum. So seedling chances are very high. If somebody has done transportal and proved to come out to this as a germ cell tumor, for radical surgery, you have to remove that part of the scrotum also along with the radical high inguinal orchidectomy. It's must to do.
The testis sparing surgery is the indications for that are synchronous bilateral germ cell tumors, a solitary testicle with a mass suspicious of germ cell tumor, or a functionally solitary testicle. This patient should be counseled regarding high risk of local recurrence with testis sparing surgery. They will require need for continued surveillance and also will require adjuvant radiation in case of local recurrence. There will be impact. The radiation therapy impacts on testosterone levels as well. So they have to be counseled regarding that as well, sir.
How do you do this surgery? Testis sparing surgery or Shivashu's
So that is also
put an inguinal instrument, take out the. So before moving the testes, you have to
vascular clamp.
Yes. Take out the testes, bifurcate it where tumor is situated, or depending on the location tumor, or bifurcate testicular tumor. Not big mark. 2 millimeters, and it's frozen section. Then close it and put it again and release the clamp, the vascular clamp.
This is similar to subcapsular orchidectomy that they do. They keep the testis.
Not exactly. Part of the tumor only, not the whole of the testes here. So you're sparing the testes. That's all.
But how frequently is possible to do PSS?
We are getting now smaller tumors. Even for the diagnosis purpose also. The markers are not elevated. It's not we don't know what's a testicular tumor or not. Then the Shivashu's maneuver in these cases.
These patients in whom a partial orchidectomy is possible, that means the tumor is within the test.
Within the test.
So how does the patient present? How is the diagnosis made in these?
Generally, they come with a testicular pain.
And ultrasound.
Yeah, on ultrasound, they get ultrasound done. For the sake of hydroxyl found a small tumor. And even on the opposite side, also you find some small tumor, which then testes are normal. Then this is sparing surgery. But young patients, not
What is preferable? Suppose you have a unilateral small intratesticular tumor. Is it better to do a total orchidectomy or because the other testis is normal?
it's normal. Yeah, you have to do the unilateral one in that case.
So is there any specific indication of partial orchidectomy?
Bilateral involvement of the small tumors are there. Young patient is there in that case.
If it is a unilateral tumor, you would
Complete
do a
orchidectomy.
total inguinal.
In post-chemotherapy setting, it should be referred to high-volume centers for surgical reduction of masses post-chemotherapy. Post-chemotherapy retroperitoneal lymph node dissection is indicated in patients with metastatic non-seminomatous germ cell tumor with a residual retroperitoneal mass following systemic chemotherapy and normalized post-chemotherapy serum tumor markers. However, it is not advocated to do in all the settings. They have recommended to do it in cases of high-volume centers only if it is needed.
Why? Because of the
The injury to the nerve plexus, nervous system.
We didn't discuss that, but what is the current status as far as the lymph node spread and lymph node dissection in retroperitoneal sarcoma is concerned?
So the retroperitoneal sarcoma lymph node is layer. So when we do surgery, if we find lymph nodes are there, we remove those lymph nodes along with that.
There is no formal lymph node dissection.
Nothing like classical templates and all, they are not there with us. But if during surgery we found, we remove that area to the lymph.
Malignant germ cell tumors in case of in females, that is immature teratoma. So stage 1, that is determinoma or immature teratoma, you can just observe in these patients. I mean,
this is all for males also.
so then, so would the treatment regimens be similar because they have mentioned particularly this in under the heading of ovarian cancers only?
Yeah.
Yes, NCCN has mentioned this under ovarian cancers only.
They are histopathologies of testes also.
So it would be similar because they did not mention.
Yes.
And in stage 2 to 4, chemotherapy.
Here we are talking about testicular tumors. What you are showing is the testicular tumor.
No, sir, that is done, sir. They have come to malignant germ cell tumors for ovarian malignancy, sir.
Ovarian malignancy. But they will not come under the heading of retroperitoneal tumors. They are separate pathology. They are not retroperitoneal. Ovary is not a retroperitoneal structure.
Teratomas, they have mentioned. Okay.
Retroperitoneal teratoma is a different thing. What Dr. Nitin is saying, if you have an ovarian tumor, it is classic. It is not mentioned as an ovarian tumor. It does not come in the definition of retroperitoneal.
Ovary is an intraperitoneal.
Yes, sir.
So it's not, it doesn't come under the heading of retroperitoneal.
So again, sir, the regimens are similar to that of what we have seen in testicular tumors. That is BEP, that is bleomycin, etoposide, and cisplatin, sir. The regimens are if there is recurrence in these patients, sir, they're given high dose chemotherapy, that is paclitaxel, ifosfamide, and cisplatin, sir. Sir, what I could search through all the literatures was that chemotherapy, except retroperitoneal sarcoma, they have not any different role in other kind of tumors. Even malignant histiocytomas as well as neuroschwannomas, except one in liposarcoma, they have not mentioned any some form of yes. Otherwise, except retroperitoneal sarcoma, there is no response in any other form of chemotherapy. More so, literatures also said that they might include GIST in. Currently, it is another group of tumors, but they are trying to include GIST also in case of retroperitoneal tumors. So, in future, the studies and trials are going on regarding inclusion of
GIST are generally not
sarcomas. Yes, sir.
So GIST are contained in benign conditions. They respond quite well to imatinib. It's a very good response rate. You know, get volume decreases to almost millimeters in size. Depending on the location where it is arising from. If it is retroperitoneal, then you say as histopathology from retroperitoneal tumors.
Currently, they are separate. They mentioned it as a separate entity, but they are planning to incorporate. Current discussions are going on in the NCC panel to include this and as well as the desmoid tumors arising from the retroperitoneal also to be included in this category.
Now there are targeted agents also for these TKIs and all, they are responsive. So they are coming considering under the heading of sarcoma also.
All good.
That's the only change I see in the last 1 or 2 decades is this role of neoadjuvant and intraoperative RT. Earlier, we used to say that retroperitoneal tumors, there is nothing else but surgery.
Surgery is the mainstay. Except like, as I said, as well as liposarcoma, they are liposarcoma is slightly responding to chemotherapy. So we are incorporating unresectable liposarcoma. We do neoadjuvant chemotherapy and then proceed, reassess the case and then go for surgery. And radiation therapy definitely, depending on the location of the tumor of the disease and post-resection residual disease, how much is left behind.
There are 2 students if they want to ask.
Students wants to ask anything? Vish Kumar, Lata? If you have any questions, then we can close the session. Okay, thank you. Thank you. Thank you very much.